All right, let's talk pathomechanics and biomechanics. So, how the shoulder moves and what is happening and how it leads to injury. So, this is the most complex joint in the body. And so, to talk about pathomechanics and biomechanics, it could be a whole class. So, I will do some foundational things that I think will be important to build off of if you go into an MAT or DPT program. But for now, we're just going to focus on a few important things. So, when we talk about the movement of the shoulder, we have flexion, extension. So flexion in front of you, extension behind you, abduction out, adduction towards your body. Then you have horizontal abduction, adduction where you're at 90 degrees, horizontal abduction away from the body, and horizontal adduction toward the body. You also have external rotation and internal rotation. So the shoulder has a lot of movement, a lot of that coming from the rotator cuff itself that I talked about in the soft tissue section. So that's important to understand. Please go through the module and look at all those different muscles acting on the body. Something else that I didn't get into that takes a really long time, but an important concept to understand is that the way the scapula moves on the thorax is really important because it's connected to the glenoid fossa. The glenoid fossa is coming up from the scapula. And depending on if this shoulder blade, the scapula is not moving correctly on the thorax. So if it's not able to tilt, it retracts, it protracts. So it moves toward the spine, away from the spine on the outside of the body. It can move upward. It can move downward rotation. So it rotates, it tilts. There's a lot of motion here. And it's putting the glenohumeral joint in a good position to make sure the muscles are acting on it the way that it should. If it's not able to move in the way that it's going because of some muscles, so you have rhomboids, you have levator scapula, you have trapezius, you have a lot of muscles acting on the scapula, including the rotator cuff. Any of those muscles are tight or weak or spasming, anything that's going to create that scapula for moving, then you're going to create these terrible patterns, movement patterns of the scapula where it's not moving the way that it should. And what results from that is injuries to the glenohumeral joint. Usually the supraspinatus and the long head of the biceps are really common culprits of that because they're the ones that are often lifting the shoulder and doing a lot of movement there. So your supraspinatus is coming in, and that brings us to subacromial impingement, which is one of the most common pathologies we see in sports, but in general with like laborers, anyone that's working in overhead area. So where this AC joint, so the acromion, underneath that subacromion, that's the subacromial space. In that space, you have this supraspinatus. The supraspinatus is a thick tendon from the rotator cuff attaching on the greater tubercle of the humerus. It is doing the abduction and the flexion, but in the plane of scaption, which is in between. So we're basically going to be in flexion and we're going to horizontally abduct to 90 degrees. So in between, and this is a functional motion, this is where the supraspinatus is the strongest. This is a primary mover right here in this motion. So because of that, it really can get pinched, especially when we internally rotate that shoulder and crank it. So when we crank it, it's really becoming pinched because this is going to then wrap around the front. Running right underneath that is the long head of the bicep. So it's running down the front through this bicipital groove here and in, and the long head of the biceps attaches on this supraglenoid tubercle, which is, it has to attach through the labrum. So it's attaching to the superior labrum, and that's a problem. So first, subacromial impingement, if this supraspinatus is not operating and working the way that it should, it will get inflamed and angry. Also, it will be weak and won't be able to function very well, especially in this range, this 90 to 120. So you might be strong up here using those traps and other scapular muscles, and you might be in deltoid, and you might be strong down here using your lats and other muscles. But right in here is your supraspinatus. When this is being pinched or it's angry or it's just not working, it's maybe just weaker than it should, then the long head of the biceps is going to start functioning as a supraspinatus. And you can see this is much smaller. It's like a cord. It should not be operating that way, and it will get angry and cause bicipital tendinitis or biceps tendinitis, or tendinopathy, we like to refer, because we don't know if it's just inflamed or if it's actually starting to break down. But either way, it becomes a problem. And then it puts pressure on the supraspinatus, and this space is very small. It doesn't have space for one of these tendons to be angry and inflamed, and it will create a pinching sensation there and create issues. You have to really get to the biomechanical underlying issue, which is usually coming from the scapulothoracic joint, in order to alleviate this and be able to work on the supraspinatus and make it stronger and take pressure off this long head of the biceps. With that said, this is kind of all working together. The long head of the biceps attaches to the labrum. So the long head of the biceps also does a lot with our cock up phase. So when we're in this motion and we're really cocking back to really get velocity, especially in throwing, or volleyball, tennis, anything where we're really going back. We're really stretching out that bicep and we're pulling on that labrum. So when we do that and we're doing quick motions and we're constantly repetitively doing that, it will do a peel back on the labrum and cause the labrum to then pull off. And that's the superior labrum. And that's what's called a slap tear. Slap tears can also come from traumatic compression in the area, but it's usually a chronic thing from that peel back of the long head of the biceps in overhead athletes. And it's the slap tear stands for superior labrum anterior to posterior. So it's tearing the superior part and it reaches all over the top part of the humeral head. So these are the main injury patterns. Slap tear, subacromial impingement are really common injuries, but just know that the scapulothoracic joint plays a really important role in how the humeral head is positioned, since that glenoid fossa is coming off that scapula and positioning the glenohumeral joint. So it all works together. It's important whenever there's an injury to the shoulder to assess the entire shoulder girdle, which is all three joints of the AC joint, scapulothoracic, and the glenohumeral. So if this is confusing at all, please go back and rewatch this video. Make sure you're learning all the muscles from the module, and then reach out if you have questions.